Hello my beloved doctors. In this video we will learn how to examine neck veins, how to answer the most critical questions regarding this, and we will learn how to differentiate between the arterial and venous pulsations, as well as the correlation between the neck veins waves pulsations and the cardiac cycle. Alright, it's very interesting. So let's start. The first step in neck veins examination is the patient position, your patient position. Patient lies, as you see here in the photo, at 45 degrees. 45 degrees. Why 45 degrees? Because at this position you will have the most clear image of your neck veins, and ask your patient to look to other side. We usually use the right neck veins for examination, alright, because it's more straight and more clear. And usually while we are examining your patient, you will be standing on the right side of the patient, so ask your patient to look toward the opposite side and examine the neck vein of your patient. If you doesn't see at this level, you can move your patient up 15 to 30 degrees or down 15 to 30 degrees to have the top of the venous pulsation, to see the most upper level, the start one, because you will measure this column. You have a paper like here, like this line, a paper like here to assess the surface of the neck vein pulsation, and measures the length between this and the sternal angle, alright. This is the length. So suppose it's like 3 centimeters, add for this 5 centimeter till the mid right atrium, and it will be like 8 centimeter H2O jugular venous pressure, which is physiological. It's from 7 to 10 is accepted. Below this, your patient is hypovolemic. Above this, your patient has a hypervolemic state, right? So the first thing to do is your patient position. When should you move your patient up 15 to 30 degrees, and when should you move him down? You should move your patient up to see the most upper level of the neck veins if your patient has a full neck vein. It's like a bottle filled with fluid. The neck vein is like a bottle filled with fluid. If it is full, you should move it up to see the surface. If it doesn't have much fluid and it's very low at this position, you will not see anything. You can move your patient down, even more than 30 degrees to see, right? To see the top. But I would like to assure you that at this stage, your patient is so hypovolemic. Your patient is severely dehydrated, alright? So this is why you should move your patient. Vein location. The external jugular vein, as we discussed it before in the last video, is located superficial to the sternocleidomastoid muscle, and the internal jugular vein is lying just beneath the sternocleidomastoid muscle. You will move the head of the patient to the opposite side. So you will relax the sternocleidomastoid muscle, and you will have the best view of your neck, of the neck vein of your patient. Then you have to interpret the waves of the neck veins. The neck vein pulsation is wavy. The neck veins pulsation is wavy. It has three up waves, A, C, and V, and two drops, X and Y, and it's repeated all over the cardiac cycle. A, C, and V, X, Y, down. A, C, V, up, X, Y, down. By the way, the C wave, you will not see it. It is just traced, but clinically, you will not see it. You will see A and V, X and Y. Okay. Venous pulse pressure estimation, we discussed before. How you should differentiate between arterial and venous pulsations. The arterial pulses from carotid artery is jerky. It's boom, boom. But venous pulsations is wavy, as I told you. The arterial pulses is palpable. You will feel the pulse exactly like you are assessing the pulse of your patient in the radial artery, the same. But the venous pulsations is not palpable. Arterial pulse is resistant to compression. If you compress at the root of the neck, the arterial pulse is still present, but the venous pulse can be eliminated if you press at the root of the neck. Arterial pulse doesn't change with body position, but as I told you, venous pulses changes with body position, up and down. So arterial doesn't move. It's very strong. Doesn't change with respiration, but actually venous pulses it changes with respiration. By the way, I told you in the last video that we have cosmal sign, which means that the venous pulses rise with inspiration if the intrathoracic pressure is very high, like in constrictive pericarditis, like in pericardial tamponade, like right side failure, pulmonary embolism. Also, ask your patient if he doesn't have any of this. Ask your patient to take a deep breath. You will say that neck veins is collapsing because blood goes fast to the right atrium. Ask your patient to exhale. The venous pulses will rise because the intrathoracic pressure will be high, the venous return will be decreased, the neck veins will be more congested. Arterial pulses doesn't be affected by abdominal pressure, but venous pulses is affected by abdominal pressure. That's why we have hepatojugular reflux. If you press on the lever in the right hypochondrium of your patient, the neck veins pulse rise if he has right side heart disease. Okay, all right. The most interesting thing is to correlate the neck vein waves with the cardiac cycle. The cardiac cycle. All right. What will happen is, first we start with A wave. A wave. A wave is related to the late diastolic phase of ventricular filling. The diastole starts with slow phase in which blood goes from the atria to ventricle by gravity, and then the last 25% of the right atrium or left atrium content is pushed to the ventricle by an atrial contraction. Atrial contraction. So the late diastolic right atrium contraction, we are saying right because we are examining usually the right side, the right neck veins. So this contraction of the right atrium is transmitted to the neck veins, causing A wave upstroke. A wave. So A wave is correlated to the late diastolic right atrium contraction, which is called atrial kick. Okay. By the way, atrial kick can cause an added sound, which is S4, to be auscultated if your patient has LV ischemia or left ventricular hypertrophy. And then when the whole content of the right atrium is now at the left in the right ventricle, the tricuspid valve closes and isovolumetric contraction starts, which push the tricuspid valve upward slightly, causes C wave due to isovolumetric contraction. Tricuspid valve closure causes small upstroke, which is the C wave. You will never see it clinically. Okay, just you have to know. Then the right atrium, we are like watching what is happening in the right atrium. Okay, right atrium pressure drop and expand to fill with the blood. This is the X descent. This is the X descent because the right atrium pressure dropped to receive blood, expands to receive blood. So the pressure is dropped. This is transmitted into the neck veins as a downward wave, which is the X descent. X descent. What we are saying is a physiology. Okay. Then the right atrium volume rises again because he is filling now with the blood. This will be transmitted to the neck veins as a positive wave, which is the V wave. V wave. It's related to volume. V wave is related to the volume in the right atrium. Volume in the right atrium. Okay? Then tricuspid valve will open and right ventricular diastole will start. The blood will pass by gravity in the slow phase of the diastole, slow early phase of the diastole, and the pressure will drop again in the right atrium because he is losing its blood to the right ventricle, so will be transmitted as a downward wave, which is the Y descent. Y descent. Okay, so again, this will be followed by the Y descent will be followed by an atrial contraction in the late diastolic phase with an A wave atrial contraction. Then the tricuspid valve close, transmitting this C wave. Then right atrium pressure drop to receive blood. This is X descent. Then the right atrium volume will rise to give us V wave. Then the tricuspid valve will open again to allow the blood to pass downward from the right atrium to the right ventricle, gives us a downward wave, which is a Y descent, and so on. The cycle will continue. Right? So you will have A wave, which is a diastolic wave. A wave, which is a diastolic wave. It's a late diastolic wave. A C wave, it's just in between the diastole and systole, because here the tricuspid valve closure. This is the tricuspid valve closure. Alright? Here is the S1. The S1, because of the tricuspid valve closure, and on the left side, the mitral valve closure. Okay? This is systole. With systole, the right atrium pressure will drop, gives us X descent. Then it will fill with the blood. This is the V wave. Then the tricuspid valve will open again and allow the blood to move downward from the right atrium to right ventricle with Y descent. This is diastole. This is the early diastolic phase till the A wave due to atrial contraction, and so on. What's after S1 is systole. What's after S2 is diastole. Alright? I wish it's clear. I wish you love it. Stay tuned because the next video I'm gonna explain for you a very interesting topic. It will be how to correlate the neck vein waves with cardiac diseases. Cardiac diseases, which is very attractive for your examiner in the test. Stay tuned. Bye.